Grab a seat. We have a couple of those standing chairs over here. We have 2 seats front and center. So I'm Aaron, founder and CEO of Mobile. So I'm sure I've seen a few familiar faces. I know some of you have heard this before, but bear with me if you have. So what we do, we basically focus on closing our data skills gap. We do that through events like this. We do stuff like this almost once a week, at this point 2-3 times a month. So it's always practitioners who do this every single day, different industries, different topics, all data related. Ultimately, it's how do you use data to get better at what you do best. So upcoming stuff that we have, well, all of our instructors are people like this. So everyone, per practitioner, Nielsen, Grubhub, Trunk Club, Google, you name it, we probably have them teach for us. Upcoming events for everyone, assume everyone here is interested in healthcare stuff. We also have in February direct analytics from Northwestern Medicine. So you'll be doing also some more healthcare analytics talk. We've got someone focused on logistics. And then we've got more data-driven culture. So how do you go from saying we want to use more data to make better decisions to implementing that throughout your entire organization. Anyone interested in our data classes, if you're like, hey, I want to level up, I'm a marketing manager or a product manager or finance or what have you, and I want to make better data-driven decisions, or I want to learn how to ask better questions. So data class, that's you learn SQL, Tableau, it's in person, 5 hours a week. If anyone's interested, feel free to come by and say hello. If not, also come by and say hello. We'll be here afterwards. Other last minute announcement, we'll be sending out the deck after the event, so next couple of days. So you can still take pictures and stuff, but you'll also get that as well. So you'll be able to relive all the exciting moments we had. With that, hand it over.
All right, perfect. Hello, everyone. My name is Pam Taylor. I'll do a bio in just a moment, but before I get started, I would love to just poll the audience so that I have a bit of an understanding of who's in the room. Is there anyone in the payer space by any chance? Healthcare payers? So you're an insurance person, which is totally fine. A provider? Any doctors, nurses, hospitals, anything? Yes. Okay. Data scientists? One. Budding data scientists? Okay. Data visualization folks? Anybody in like bio, life sciences, pharma? Okay, great. All right, those are all the categories I came up with. I'm sure there are many other wonderful things, but that just helps me with the presentation. I know where to dive a little deeper or keep a little higher on the surface. All right, so Healthcare Analytics 101. First things first. Okay, this is, as Promotable said, this is designed to be a 101. If we get into things like machine learning algorithms, which we can, way at the end, but this is really designed to be a presentation for everybody and kind of an overview of managed care and some of the things that we do at my company using data and analytics. Okay, so what will you learn? We're going to talk about just the basics of the healthcare analytics space. This is so broad. You can put just about anything into this category. It's kind of like math is cool. There's so much that you can do with it. The managed care overview and what exactly does this mean? So I'm going to talk about managed care specifically in the U.S. and what that means for many people who are in this room, or once you turn 65, if you're a citizen, you will be on the Medicare space. And then also just some highlights of some different use cases. So some really cool companies doing some cool stuff. And you can see where data is being utilized to improve human health, which I think is really powerful and amazing. Okay, what you will not learn, I'll be really clear. You will not learn how to be a data scientist. You will not learn how to be a surgeon. And then often in healthcare, especially managed care and government-sponsored managed care, I am not going to talk about how to fix Obamacare, how to help Trump. I'm kind of dealing with the debt that we're given, and so I'm going to talk about what we're doing, but not how to change things or anything related to policy. And then I don't have any insight from Google, but we'll talk about what they're doing, what we're doing at the end of today. So I can only go with publicly available information. I don't have any stock tips or secrets. All right, so a little bit about me. This is me. I was recently on the slopes in Colorado, and so I'll talk to you about that a little bit. I'm an engineer, so way back in the day I was an engineer. I also have an MBA. I'm a data scientist, certified analytics professional. I also have done coursework in biostatistics epidemiology, and then I also do program management. So that all kind of culminates in the role that I have now, and I'm the director of quality and affordability initiatives, which basically a very large project portfolio of anything having to do with the care of the quality that we deliver to our members, as well as the financial return and the portfolio of projects that we run to make sure that our programs are profitable and deliver value to our members. And what that really means, for those of you who may not know Wellcare, because Wellcare is specific to Medicaid and Medicare only, we are also in the process of being purchased by Centene. And last year, Wellcare purchased Meridian, which is specifically in Michigan and Illinois. So put all three of those mergers together and kind of have a microcosm of what's going on in healthcare overall. We're in the process of being acquired. And so what that means, I cover specifically Medicare, Medicaid, Illinois, Michigan, and then national programs as well. And then just to tell you about my downhill skiing, so healthcare is everywhere. This is why I think this is a big deal. I was recently in Colorado, so a shout out to Centura Health, who was in Colorado and helped one of my co-travelers with some altitude sickness. So even when you think you're on vacation and you're hoping healthcare isn't a part of it, it actually is. So a shout out to them, they did a great job. All right, so I titled this talk From Proverbs to Predictions. So this is what data or analytics used to look like. Your doctor would say something like, an apple a day keeps the doctor away. Like they predicted that if you ate some apples, you would never ever have to deal with anything ever again. It was coined originally in 1857, revised in 1913, and fortunately we have a lot better information since then. All right, so healthcare analytics. I mentioned at the beginning that this is really broad, and so rather than just give you my opinion, this is actually a technology survey done by HIMSS, which is one of the leading organizations within the healthcare information space, and just polling the different folks that they, in their network, sort of, okay, we'll look at that. Analytics and data management is the number one thing that they think will drive value. And that can go all the way up to really sophisticated things. So AI, machine learning, very sophisticated, cloud computing, FHIR, which is interoperability for records, some different things that are going on there, all the way down to things like drones. So if you were to even just use this as kind of a snapshot of what the healthcare analytics space could be, there's a lot that's in here, including things like blockchain that has a lot of hype in other industries, but anything that's cool in tech somehow ends up being cool in healthcare too. But analytics and data management, which I would consider some of that foundational work, is the thing that rises to the top. So we'll go through some of these, talking through kind of the scope or the life cycle of analytics and what it could mean. Okay, so why is analytics so important? It's certainly a buzzword. This is an article from JAMA, which is the Journal of the American Medical Association, very well respected. And this is for 1 year. So the estimated cost of waste in the U.S. healthcare system ranged from $760 billion to $935 billion, accounting for approximately 25% of healthcare spending. And so waste doesn't necessarily mean it's intentional, it doesn't mean it's unintentional, it just means the service is not being delivered to the right person, the right place, at the right time. And that is a lot of money, a whole lot. And if you are a US taxpayer in any way, shape, or form, you pay for this. This is where a lot of this money goes. And so we'll talk about managed care in a minute, but the managed care organization, on behalf of the US government, administers these health plans. So you write that check to the government then gives the contract to a variety of different organizations that they work with. But the reason you should care is that we use analytics to make sure that this waste is not distributed as much as it can, or we catch opportunities to improve this waste. All right, so managed care analytics. I'm going to go through this pretty high level. This is, again, as I mentioned, very US-centric, and all of the information that I'm using is publicly available, so this is available specifically from Medicaid.gov. And because we're going to send this out afterwards, you can read this at your leisure. I just wanted to make sure you had all the information. It's pretty hefty. But the takeaway is the things that we're looking at are cost, utilization, and quality. So this is really what we're trying to do. And what a managed care organization does is we basically get what's called a capitation or a payment that is set per member per month, and then it's up to us to manage that and manage that person's care and deliver the care in the most cost efficient, utilizing kind of the right services, and then making sure that they also get that quality service as well. So our team spend a whole lot of work contracting with providers to make sure that we have different specialties, different geographic reaches, and a lot of different ways to deliver care for our members. And as I mentioned, again, this kind of all comes back to analytics. One thing that my team specifically does is we do look for those opportunities to eliminate waste. And as I mentioned at the beginning, it can be both intentional, so is someone billing for services that they had actually provided, or it could be unintentional, meaning they think they provided service A, but they really provided service B. And so how do we make sure that the billing matches the service that was actually provided? Okay. So I'm going to give you just a few examples. So for cost. So as I mentioned, cost, we really are looking to negotiate the best care services for our members. So we have people that contract with hospitals and providers and make sure that they're able to deliver care for our membership at a price that is cost effective. So if you didn't have insurance or you weren't in a managed care organization, you would go to the hospital or the provider and pay whatever the provider would charge. In this case, there's a lot of scale, so there's a lot of people that have Medicaid or have Medicare, depending on state or federally funded, and based on that scale, we can negotiate better contracts and better rates. And then also ensure that the costs are appropriate for the services delivered. I heard an analogy recently that healthcare in some ways was like buying an orange, and you go to the grocery store and you pick up an orange and you take it to the cash register, and then someone tells you that this orange is now $600, and you say, whoa, I don't want this orange isn't worth $600, and they say, too bad, you bought it. So in that way, we want to make sure that costs are appropriate for the services delivered. So most folks in this room, you know that an orange should not cost you $600, but when it comes to healthcare, it's very difficult to figure out what something should cost. And so that's one of the things that the managed care organization does on your behalf. Utilization. The membership receiving the right care at the right place at the right time. So this can be anything. It could be something as simple as a blood test. If you're using a blood test for some sort of diagnosis, making sure that that test that was done is actually relevant to the symptoms that the person has. It could also be making sure that if you are going to the hospital, that you really needed to go to the hospital, and instead maybe you should have seen someone ahead of time. So we spend a lot of time focusing specifically on preventative medicine. Oftentimes, especially within the Medicaid or the Medicare population, there can be people who postpone going to the doctor and getting some preventative services. and we'll wait until something gets very, very bad, and then we'll have to go to the ER. And so we want to make sure that if people don't have access to get to the doctor, or they don't know where to go, or there isn't someone in their geographic area that they're used to seeing, that we help provide those services so that they can see doctors on a regular basis. And then last but not least, quality. And we have a group of people who partner with our providers to make sure that the services that they're delivering are actually of the most quality for our membership. And there are a lot of different metrics that we have for that. Some patients are very ill, so it's not that you've seen more ill patients, therefore your metrics are better or worse. It's really giving providers some resources to understand their population. We do a lot of demographic work and help them understand, what sort of behaviors their patients might be exhibiting outside of their office. They only get a very small time and a very small window to see someone. So often they can get more information because we have a longer history with the person. We also work with them to address specific member needs and care gaps. So a very simple one is mammograms for women over 40, flu shots when it's flu season. So we spend a lot of time reaching out and making sure that members are attempting to get as much preventative care and take care of themselves as much as possible. And then ratings reviews. So there are reviews both at the federal and the state level to make sure that all healthcare MCOs are rated, and they're all rated under the same basis. And those ratings are published. And then most MCOs are actually compensated based on them. So it's really incenting the MCO to do what's best for the member that they serve. And so, you could look up the stars of the NCQA ratings for all of the various plans. It is an extensive scorecard, like nothing you've probably ever seen. It's so detailed. Some of it is based on survey results. Some of it is actually based on going into individual charts and making sure that the care provided was correct. So it's very, very detailed. And so I use these as examples because each one of these, and many, many more, also have analytics that support them. So we don't wait until the end, for example, for quality to say, oh, I wonder how we did. We're constantly looking at things, updating the models that we have to make sure that we're on track for the performance that we want to be giving our membership. So this is not unique. We're going to go through it. This is various levels of analytics maturity. And as we go kind of from the bottom towards the top, we end up with increasing sophistication. So descriptive, diagnostic, predictive, prescriptive, and then cognitive or some artificial intelligence. And I'm just going to go through some examples of what does this mean exactly. So starting at the bottom, and I'm going to work my way up. So descriptive, basically what's going on. It's just a snapshot in time. You can use everything from Excel to do this. Any information that you have available to more sophisticated things like Tableau or Click. So diagnostic, why is this happening? So that's another level, the increasing level of sophistication. So not just what is happening, but why is this happening? What's the cause? How do we solve for this? The third level, predictive. So what will happen? Given what I know, what do I think will happen in the future? So this is where you're taking that level really further into data science, where you're trying to predict, running some algorithms to see what would happen. So prescriptive. So I now have the information about what I think will happen, but what do I want to happen? And so that's how I would use prescriptive analytics, is to try and manipulate some of the factors that would go into my model, or which things are changeable, so that I can get the outcome that I am looking for. So that's prescriptive. And then last but not least, and this is the one that has a whole lot of buzz right now, is cognitive, otherwise known as artificial intelligence. And it's trying to learn from the data in a human way. So it's kind of trying to replicate things like decision making, observational information, reasoning, rationality, which are all very difficult for a computer to do on its own. So I'm going to go through some examples. Just 3 today. We'll go through the descriptive, a predictive, and then the cognitive. All right. So descriptive. So these are some examples from managed care, some things that we do. So describe what's going on in the market or a hospital or a subpopulation. So one of the things that we might do, for example, being here in Chicago, we would look at information for Cook County, specifically to see what trends or different disease states we might be seeing more of here in Cook County, as opposed to different areas in the state. We also do this on a national level. We look for different populations. We can also even see, different disease burdens. So who has diabetes versus who might not have more complicated conditions. And so we keep an eye on all of that. We also look for things like hospital or provider differences. So we can compare, the outcomes from hospital A versus hospital B, or people who to go see a doctor in region A versus region B. But there are lots and lots of comparisons that we can make to ensure that our members are getting the best care. We also then will develop plans to share that information back with the provider or the doctor to ensure that they know that their information is being checked up on and making sure that they are delivering quality care as well. The other thing that we do, this is similar to any business, even a nonprofit, we would align with our strategic plan. So just like any business, you do strategic planning. What do you want to achieve? How do you achieve that? That's the same for healthcare. Even if you're a nonprofit in healthcare, you still only have a set amount of dollars that you're able to use. And so how do you deploy those resources efficiently? So we look at things that are financial metrics as well. So things like the cost of a service, the cost of running our business, and then any utilization of services. So do we suddenly see an uptick in things like ER admissions, or not that you can do a lot about this one, but if there's a flu outbreak, these types of things come up in our data and we can see exactly what's going on. And then highlighting treatments and outcomes or areas for opportunity. We can look at, as I mentioned, admissions, who's being admitted in the hospital, the length of stay, are they staying longer than we would expect them to stay? And not are they staying longer than we would expect based overall, but we look very specifically at if you have treatment A, then are you in the hospital for a certain amount of days or a certain amount of time? We can really drill into the specifics for each one of these areas. All right, so here's an example. Since we're based here in Illinois, I thought I would pull this one up. As I mentioned, I have to keep this all publicly available information. So this is from Medicaid.gov. Very simple, descriptive. For those of you who are into visualization, this is a geographic one on a lovely map here. And this talks about Medicaid and CHIP, so children's enrollment here in Illinois. And then, of course, the big disclaimer, so they tell you exactly what this data is, how you can use it, and how you should not be using it. Medicaid.gov, not that I think anyone spends a whole lot of time there, but if you do, there's an endless amount of data that's actually publicly available because you, as tax-paying citizens, have access to that data. And you can click around, it's kind of cool, you can click around in different states, and there's plenty of other things that you could do with this. All right, so we'll go up a level in terms of sophistication. So predictive. So how can I predict what will happen next, and how can we improve outcomes? So if we know from past performance, either work that we've done internally, or even something that might be published in a white paper, we can then take best practice information to help our patients and our members get more effective treatment. So a simple one is in the winter here in Illinois, we know that people who have lung conditions, so specifically asthma and COPD, start to have more difficulty with their conditions. And so we can reach out to them and attempt to make sure that they are stable, well managed, taking medication, if they have any other challenges that might be going on in their life. The idea is that we can address those concerns before they become problematic. And so that is what we do with a lot of predictive. So that one's a pretty simple one. It's seasonal, same sort of thing with allergies, all sorts of different things. But then there's also things that we add into our modeling that might not be quite as apparent from the start. So we have a certain number of resources. We have folks, people, care coordinators, they're typically nurses, who reach out, but we have a limited number of people that we can deploy. And so since we only have so many people we can reach out to, how do we decide how can we best manage the care for the people that need it the most? And so there's some work that we do behind the scenes to try and figure out who are those people. And not only do they have certain conditions or things that we would see medically, there also is a need-based element too. So who needs care the most, and who needs someone to follow up with them? So if you have a serious illness, but it's not changing, and you're on your medication, you're seeing your doctor, kind of doing everything that you can do, and you're stable, you don't really need someone to be checking out with you as often as if you're newly diagnosed, maybe you have a lot of other complicating conditions, maybe you have some complicated family situations, housing instability, some different things that could be going on. And so that's the type of information that we try to incorporate in our work as well. And then last but not least here is who's willing to accept care and or change their behavior. So just because you have some sort of model about who you think could use help does not mean that that person is always receptive to that help. And we do a lot of work of reaching out to people who may be difficult to contact for whatever reason, and try to focus on the people whose behavior or situation could change with some actual assistance. So, as a predictive example, this is the Johns Hopkins system, and again, publicly available. And if you're interested in it, it's at hopkinsacg.org. It's a software platform. They use it. It is statistically valid case mix methodology, which basically means population health management. There's a lot of different things that you can do with it. But I think their original article was published in the 70s on this, and since then they've been collecting data and refining it. So even though things like predictive modeling or machine learning are kind of the new cool thing, Johns Hopkins has been doing it since the 70s, and they now, I think, have over, I think they said 200 million lives on their website, but I think even more if they were to talk about people who probably use the software on their behalf. So, and they do lots and lots of different things. So everything from pharmacy management to actual medical care management, and look at different things. They say specifically things like duration of the illness, the severity, their diagnostic certainty, so how strongly they feel that the diagnosis is accurate, the type of cause, so what is this being driven by, and then the expected need for specialty care. So this is often used for a system like this. A lot of companies, perhaps if they have a large enough data set, might be doing it in-house as well. But again, so that I'm not sharing any secret sauce, I have to go with these. All right. Cognitive, artificial intelligence. So a rise of the machines. Well, not exactly. But maybe I should pull, how many people feel they have a good handle on AI? Okay. All right, excellent. Okay. So I'm going to direct all the tough questions to you guys. So I did work in machine learning, and it's a budding topic specifically here in healthcare. And I'm just going to boil it down to one of the simplest definitions I saw, and I thought it was pretty solid, which is the computer's ability to mimic human behavior or better. So depending on the application, sometimes better, sometimes worse, and I'll show you an example in just a minute that I thought was really interesting. So these are names, I'm sure, that are not surprising to you. The fact that Amazon would be in here, Google AI, and their foray into healthcare, and then IBM Watson as well. These are three companies that are doing a lot with data. And the key for artificial intelligence and the ability to mimic human behavior is usually having a lot of data. So that's why these companies specifically have been so able to make leaps and bounds. Even just Google, if you think about your web searches, they have the most data of anybody. So they're able to then make better predictions or mimic what they think you want because they have all your data. So that's why these companies have been doing so well. So just a couple of things I'll mention here. So Amazon, I think they will tell you that they built their business on this. And what they're looking at is they're saying it's solving cognitive problems associated with human intelligence, learning, problem solving, and pattern recognition. So these are the types of things that they're looking for. They're looking for use cases to be able to solve this. Google AI, they think this is pretty broad, and most of these companies do. They're not just healthcare applications. But they want smarter, more useful technology and to help as many people as possible. So certainly some altruism in there. And then IBM, so three areas of focus: AI engineering, scalable AI models, and then AI tech. So natural language processing, which is basically text analytics, trying to get some sentiment out of speech patterns, speech and image recognition. So they're calling those AI science. And then they have the next one called AI science, which is basically their research arm where they're trying to build out that next frontier. So, as an example, so this is a Google application for breast cancer detection. And the platform it's basically image recognition. So, how well does this work as compared to actual technicians who are trained to do this? So I highlighted in green the original article, and so I think there's a couple of things that are really interesting here. Is one, the original article was published in nature.com. I'm sure you all have a subscription. And theirs is very unbiased. So an international evaluation of an AI system for breast cancer. That's a statement. These are 3 other titles that are actually built from the exact same article. I didn't even realize this until I was prepping for this presentation and saw that healthcare IT says a Google platform aids oncologists in breast cancer screenings. Okay. Now the USA Today article, Google system can surpass human experts in spotting breast cancer. And then Google AI beats doctors at breast cancer detection sometimes. So this is all from the same article. And so, of course, I read the full article so I could know what was going on with this. But the issue being, we're really looking at image detection and how well a human can mimic machine can mimic how well a human does. And I don't know if anyone's ever seen a mammogram, but they're really fuzzy, they're super hard to read, it's not like some great picture. And so what they're looking for is anomalies. And even going through this, to try and validate the work that they were doing, they actually had images sent here from Northwestern in Chicago, and some images in the UK, and use those models to train the system. Even after all of that, most of the time, the image recognition software did better. Then some of the time, the radiologists did better. And then some of the times, the radiologists didn't necessarily agree with each other. And I think this is a really interesting indication of kind of what's going on with machine learning and AI and all these really cool technologies. Is there is definitely a use for it, but it's certainly not a silver bullet. So it's not the rise of the machines and we can all go home. I think it's just like any tool. It's a matter of how you use it. And then my second word of warning would be, keep in mind that even if you pull up one article from Nature, and I was very surprised to read this as well, the spin that can be put into one scientific article that seems pretty straightforward was really fascinating to me.
A question. Was there an unequivocal clinical endpoint in which unequivocally knew that the patient indeed had breast cancer?
They did. So they started out with a set of scans that had been diagnosed one way or the other, unequivocally. So they started out with a truth set and trained the model on that, and then they tested them on the unknowns. And they had the software do the unknowns first, so that researchers who were very invested in the software's output would not be able to skew it. But even with some of this, there's still interpretation, and even if you get a screening mammogram, sometimes you then have to go on to diagnostic mammograms, as well as a whole bunch of other tests. So there's certainly room for improvement. I think they said, especially in the UK, in the UK, 2 radiologists have to review 1 scan, where here in the US it's just 1. And they said it reduced the workload by 88%. So not by half, but not by 1 person. So, you know, an interesting statistical difference there between the 2. So there is some room there, but it's not perfect. Okay. So wrapping it up, we'll have a couple minutes here for questions too. Just the takeaways from today. So lots of info and opportunities on healthcare analytics. If you just Google it, you will have no shortage. It's a very, very vast topic, and I didn't even get into a whole bunch of stuff today. That everything that could be precision medicine, gene sequencing. There's all sorts of things that can go on. So this is just really the tip of the iceberg. Managed care is also one model utilizing these analytics to benefit our members. There are lots of other models. Even Medicaid and Medicare have innovation centers where they're testing out different methods for reimbursement, for patient care, for payment models, to try and find things that really work best within the ecosystem. So there's an innovation hub that they're also running. There's also room for improvement at all levels of analytics. So even things like descriptive, and if you work in a high-tech industry, so I used to work for Oracle, and this technology that is employed to do things like target ads on the internet and make sure that you actually bought that consumer good is boggling. And when you look at that in healthcare, often your doctor, 2 different doctors for a very serious health condition, can't actually see the same piece of information. So even there's room within healthcare for everything. And I would say it doesn't just have to be kind of that rise against the machines, AI, machine learning. There are lots of improvements to be made, even with things that are descriptive analytics. And then no need anymore, I would say, to rely solely on Proverbs. So does an apple a day keep the doctor away? Does anyone have a guess?
Sometimes.
Exactly, sometimes. So I even Googled this one, and there is a study that was done that says there's an apple a day that keeps the doctor away, and there's a study that says no, that absolutely doesn't work. And then I read 4 more articles that said, well, in this one it did, and this one it didn't, and then this one it did. So the answer is sometimes. Almost a plant. All right. Well, thank you. Questions?
Is your mammogram example? The issue is that the mammograms are
Yeah, it's terrible. I know, but they're trying to do something. So that's what they were doing. There was also one for mammograms, kidney screenings, I believe lung scans, and there was one more, and I can't remember the 4th one, but they were trying a bunch. This is the one they published. So that's probably the best of the worst. Yeah. Go ahead.
Yes, thank you very much. A very informative presentation. My question has to do with your thoughts, if any, about privacy concerns, given that recently a lawsuit was filed against Google and here at the University of Chicago about the use of so-called de-identified data and electronic health records, and the fact that you can essentially triangulate where a person is. That's nothing new about EHRs. I'm just wondering your thoughts about privacy concerns.
Yeah, I mean, as a scientist, even when I go to the doctor, they ask me, "Are you willing to release your medical records?" And I think it's a difficult subject. I would never want to say don't give any data out because then you really can't learn anything from that data. But there are ways to use de-identified data to ensure that you can't triangulate it back. So, meaning if you can get down to one individual person and the exact, I'm going to make this up, like the street they live on and who all their siblings are and where are their children, that's too much. But if you can at least get it down to a group, maybe even of like 30, and say, you would be able to tell within this 30-person cohort, I feel like that's hopefully strikes a bit more of a balance between privacy and science. The part that I think is really hard about privacy is even from a consumer standpoint, when you sign something, you don't actually know where it's going to go. You're really entrusting someone else to do the right thing with your data. And I think especially as we see things like security breaches that are always in the news in healthcare is certainly not immune to that. I think it's really challenging. But as a scientist, I think having data and trying to make use out of information that's already available without having to do more testing or more invasive work, I think is great.
So I wonder, so when you get the cases from the client, how big is usually the case? Like how many data are getting in now? And then how long the case will take you guys to finish, from like describe stage and then predictable stage and then until like AI stage, like how long it's gonna take? And what's the biggest challenge for that?
Yeah, so the biggest challenge for healthcare in general is that it, especially compared to like consumer goods, it's slow, really, really slow. So even when you get information, like claims and payments typically can take anywhere between 3 and 6 months. There are some feedback loops that we get pretty quickly, so things like if a patient is admitted to the hospital, that certainly doesn't go into a predictive model, but we know someone's in the hospital, and we can help address that specific need. So there's not only just a timing element, because they aren't all the same, but the modeling that we do, especially if it's something that relies on claims data, it will take a while.
Yeah. Great, thank you.
Ma'am, you mentioned that you work with Oracle.
I did.
They have one of the premium data analytics tools out
Yeah.
there. There's several others, MicroStrategy, some from SAP, and so on. If you were to mention one, or name one within healthcare that one should try and learn to add to the skill set, what's the go-to analytics tool? MicroStrategy, there's SAP, Tableau, there's quite a few.
I think it's hard, and I will say just because of my situation, we're on our third merger in under a year and 2 months, and none of them are the same. So I will tell you, even from a data perspective, there is not a cohesive platform that everybody runs. So some of it is grown internally. It sits on a Hadoop structure. We have some data scientists who code in R and SAS. So they sit a layer on top of that. We do some work in Tableau, but these databases don't talk to each other very well at all. And I think some of that happens within the healthcare industry because there is so much merger and acquisition activity, not just on the payer side, but also on the provider side. A lot of hospital systems change. So I don't know that answers your question, because I think we use a lot, and we don't necessarily have one platform that we use. The other thing I will say, especially being in Medicaid and Medicare, we're not a nonprofit, but we're close, and so we don't typically invest in big budget items, like or we'd never be able to afford an Oracle or something like that, because those are really, really expensive platforms. So I think there's kind of that build versus buy element that continues to go on. But I like Tableau personally. I mean, that's what I would say.
So it sounds like, in healthcare, it's all siloed. The data is the big challenge here in matter and everyone. It's how do we get our hands in data if people keep it? But even in the tool side, it's siloed. There's not one where there's a consensus. That's the one. They're at the right price, doing a good thing. It does everything. Let's go for it. That sounds like that's not the case.
No, and I think some of it is it's what people learn in school too. So we have data scientists who are epidemiologists. Some of them learn SAS, and that's what they're most comfortable in. And so that's even though in some of the more consumer spaces, SAS like kill me, but but they're kind of going by the wayside a little bit with some of the more flexible tools, I would say. But they're trying to keep up. But if the person who's running the models is a SAS expert and they're closest to that, then I think they kind of start to have a system built around them that runs SAS.
I know you touched on it before when you were talking about that example of the radiologist sometimes disagreeing with what the AI program comes up with in terms of interpreting a particular scan. But as we see more and more of these situations arising in hospitals and clinical situations, in situations where there are life and death decisions to be made, who determines what the standards are as to which entity is going to make the ultimate decision? Is it the clinician or is it the AI diagnostics? And who's making these decisions? At hospitals and in one-on-one situations.
Yeah, I mean, I don't think there's any tool, any AI tool that outweighs a clinician right now. And even this Google article, they talk very much about the fact that this is, these are in development, they're in testing, they're pilot phases. Even though they're trying to mimic human judgment, that doesn't mean they feel that they're there. But there are a lot of systems that certainly would make something as serious as a cancer diagnosis or not. There is someone who then does another check on that to make sure it's the case. But there are certainly technology elements that affect our healthcare system every day that aren't as serious as something like cancer detection. Even things like wait times in a hospital room, or who comes in first, how do you manage triage, or how do you manage patient records? So there's just an endless opportunity that I don't think human judgment cannot be replaced yet, for better or for worse.
Hi, so let's say that you're working for a clinic and you're using a patient management system. How would you go about requesting the data in the back end if it's not really given to you? There's no way to have a data dump in the front end.
Yeah, and nor would be really allowed to give a data dump. What we could do is hopefully you have a representative that you work with directly, and then they would have information about your patients and your patient population, and then they could have that conversation with you. So we have folks that do that, specifically do that outreach for clients. In our case, there's either providers or specific clinics, especially if it's a specialty area, like if you're a behavioral health clinic or a home care clinic, something like that. But we wouldn't send out the data directly either. We don't have that access. And then to the issue about security, we would ever be able to ensure that we were doing that properly.
So this is for a dermatologist. So let's say that we were to reach out to this representative, and like how would we go about getting that data? Because I mean, these are patients for the dermatologist.
Yeah.
So she's requesting it directly so that we can conduct analytics on it.
So if they should have some of that information because they would have all the diagnosis and everything that they did. So I think we would just have to figure out what those elements are that you would need. Yeah. Because a lot of it comes from the Dr. Predictive, things like diagnosis codes and all sorts of information. So they might not have a payment portion, but they would have diagnosis.
Could you give an example of how you assess gaps in care for the aggregate level? Maybe have a particular population.
Sure.
Maybe like a hard case or maybe a rare disease population. How do you look at that? In an aggregate setting to get a good idea of whether the care is a gap in care or maybe it's an anomaly or something like that.
So I will say one of the things that we do, we're very fortunate we're here in Chicago and we have a lot of universities that often will reach out to us too. So it's a two-way street. So if there's something that we see specifically around something like diabetes, which is pretty prevalent, we would say, are there specific groups that we're seeing that have diabetic condition that doesn't seem to be well managed? Is there a provider that we can reach out to? Is there a university system that they perhaps are all going to? And then sometimes the universities will reach out to us and say, hey, because we run Medicaid and Medicare specifically, they'll reach out to us and say, hey, we have a whole lot of your patients, and as a part of a grant, sometimes they'll have a grant, and then they will help us craft a program that meets their grant, but then also benefits our population.
So it's more focused on what in this scenario you're assessing gaps based on something that they've already identified, and you're validating that. You're testing them whether that hypothesis is correct. That gap doesn't exist based on the data you have on the patient.
For sure. So we wouldn't re-diagnose someone. We
Sure.
definitely, the providers and the clinicians are always that first line.
Right.
But then if they don't seem that they are taking their meds, so maybe they're not adhering to things, we will try and step in and see if there's something we can do that would even be out of the clinician's control. So like something like I'm just going to use housing instability. How could we help manage that? Even as a provider or physician, they're not going to have a great ability to deal with that either. So we try to provide some of those wraparound services for a person to help them manage whatever they have. So there's not always a cure, but being able to manage it. And we have an entire, I should also say, we have an entire clinical staff who then specializes in these areas too. Like there's behavioral health specialists, in a bunch of other functional areas. So the clinicians obviously do the best. Yeah.
So I'm an analytic consultant for CVS, called PBM.
Yeah.
Well, Wellcare's
We have
our
a
clients.
Yeah.
But anyways, I also work with Medicare clients.
Yeah.
And as you know, there's a lot of restrictions and regulations around Medicare. There's only so much we can do in terms of implementing solution programs. Like you can't, force a Medicare member to fill a generic. You can't, make them go to mail. You can't, so there's a lot of rules and restrictions. How do you get around that? I'm not privy to the medical side, but I don't know how many rules and restrictions there are on the medical side.
So it's very similar. Even on the pharmacy side, so for Illinois, they went to a common formulary for Medicaid in 2020, and that locked down a lot of the things that we can do as well. So the best I can say is for each one of the states, there's a whole different set of rules. For Medicare, it's national, so there's at least one set of rules. Is it better? Is it worse? I don't know, but we absolutely have to play within those rules too. And if we can't manage in one area, then we look for another opportunity to manage elsewhere. And it's not always the pharmacy side. So it's interesting because especially on the PBM, which is a pharmacy benefits manager, the PBM, we actually run 2 PBMs because CVS runs the welfare side, but for Meridian owns their own PBM. And so there are two PBMs in the same house that kind of have a wall between the two of them. So, can't be sharing too much information. But yeah, we have to operate under those same rules.
So I'm guessing you're the data analytics group, and then do you present the findings to another group that therefore implements clinical programs and solutions?
So, yes, both. So there's a corporate group that does things that would be all company, but then there are certain things that are state specific too. So we actually have a team that sits in each state because then they know the rules and the regulations of every individual state and how that applies to their market. So we have a team in Michigan, we have a team in Illinois, Florida, Georgia. There's quite a few different teams, and they manage local as well as the national programs.
Time for one more question.
You mentioned that about 25% of healthcare spending nationwide is wasted.
Yeah. So JAMA did. I will not claim JAMA.
Have you, in your organization, by employing analytics, do you have any metrics on amounts of spending that would have been wasted but have been saved?
Yes, so that's my whole job actually, is we go through all sorts of different things, really detailed, really detailed reports, and look for opportunities where one thing should be done and something else is being done. What I can give you is, I'll give you an example of a urine drug test. Under most circumstances, for example, you should be screening, and I'm not a clinician, so bear with me, but you should be screening, and the generic test, the most commonly used test is about 6. They scan for 6 things. If we look at our systems and we see that there is a physician or a hospital group that is always billing the one that is scanning for 22 items, and not that you don't need that, you do need that, and it's not that you shouldn't be using that, but you shouldn't be using it 99% of the time either. And so we look for these opportunities that are exceptionally nuanced, require a lot of detailed information from our clinicians, from medical billing specialists, to make sure that we are good stewards of those dollars and using the dollars appropriately. So that's just one example, but they're all kind of really very detailed projects that have to do with those sorts of things.
So would you come up on an annual basis with an overall number, you save this?
I do, and I don't think they would allow me.
Okay.
Essentially,
It's big. A little bit of a lot of money is a lot of money.
you're creating algorithms.
Some of it. Some for care, some for, I wouldn't say we never go to a doctor and say you should do this differently. That's not the case. We'll say we notice this pattern. Is this what you would expect? And if they're at some clinic that does something really specialized, then that makes a lot of sense. We always kind of, test it against reality. The population here in Cook County is very different than the population in Southern Illinois. So there's lots of reasons for things, but we just want to make sure that the reasons line up with what we would expect to see. And if not, is there an opportunity to make sure that people are getting the care that they need?
Good questions afterward. First of all, let's get into the thoughts. So a couple things. We'll be sending out the recording in a couple days as well as the slides. And then we'll be hanging out here for like 10-15 minutes, so feel free to come say hello. And then thanks for coming, and hope to see you next time.
Thank you.
I appreciate it. Those of you standing in that, thank you for standing.
Oops. Sorry. Oops.